This episode of the Seniors Flourish podcast is brought to you by the Learning Lab membership, because I get it. I was working with older adults in home health when I started out, and I was the only OT practitioner. I was new, I had no mentorship, I struggled with the little things at work, and I was so incredibly overwhelmed. I was struggling to keep up with that paperwork, and because I was working such ridiculously long hours, trying to research best practice, find all the patient handouts I needed, I just couldn't keep up with it all. And the worst part is I was constantly doubting myself. Am I really doing what's best for my new patients? That's why I created the Learning Lab, because I desperately needed a way to get organized and have everything I needed at my fingertips. So it's cheaper than a textbook, but it has hundreds of treatment idea videos, patient handouts, evidence-based resources, and more right at your fingertips when you need it. So join today at seniorsflourish.com/Learning Lab.
Welcome to the Seniors Flourish podcast, where it's all about helping occupational therapy practitioners disrupt the norm by throwing away the rainbow art and being the best you can be when working with older adults.
Welcome everyone to the Seniors Flourish podcast. My name is Mandy Chamberlain. I'm an occupational therapist, and I love to talk about everything about occupational therapy and specifically working with the older adult. If you are new to the podcast, welcome. I'm so glad you're here. And I love connecting with all the listeners. So find me on Facebook and Instagram, and I'm kind of everywhere. But today we are talking with Karmella Bognot. She's an occupational therapist, about hospice, palliative care, and occupational therapy. And we connected through Instagram. So that's why I love social media. Isn't it kind of fun? I love that. So welcome, Karmella. I'm really happy you're here. Isn't it fun that we connected? Isn't it so fun that you can connect through Instagram?
Yeah, I mean, we were just talking about how technology sometimes is more, problematic, but in certain cases like these and connecting, it is such a good tool. So
I know.
Thank you so much for having me.
Oh my gosh. Of course. Thanks for being a guest. I think this is a topic that I have just a very little bit of personal experience with. When I did when I worked home health at the beginning of my career, it wasn't a home health and hospice. It was just home health, but we don't have a hospice center in my area. So I got to dabble a little bit in hospice, but it's exciting to talk with someone who that's what you do. Even if it's like a new job or a first job or whatever, you know what I mean? It's just I'd love to kind of dig in. So Let's just start out with your OT journey, kind of how you got into OT and how you got to what you are doing today.
Perfect. So I'll probably go back all the way to probably when I was a young girl. I mean, I feel like ever since a young age, I was the type of person who just tried to make meaning of my own life and, just really introspective. I had my first diary at 6 years old, and I think I still have it somewhere laying around.
That's so great.
And so, as I started to get older, I knew growing up I wanted to do a career that helped people.
Yeah.
And then in my teenage years, that, I guess, belief or desire was more reinforced. So I had early experiences with death, which, I think goes into the whole line of, things come in full circle, and right where I am is right where I need to be. But teenage wise, I had a sister who was a year older, and she had taken her own life. So, the whole suicide, depression, that a lot of that plays into hospice. I also had my mom, who 6 months later, after my sister had passed away from cancer, she was diagnosed when I was in 6th grade. But, I think the physician had given her 6 months or less to live, but she trekked on for a good 2.5 years. And
wow.
Yeah. So that was early experience. And, I think that even just amped up my whole just philosophy into just making the most out of what's given to you at the time. And, so then I, entered high school, college. I finished my undergraduate in kinesiology, allied health. I like the elements of, it being science-based, but also, a lot of the courses focused on the mental health aspect of it.
Yes. Yeah.
And so I graduated from there. And for a year and a half, I was fortunate enough to work as a PT tech for a private outpatient clinic over here. And that, I think, introduced my love for the older adults population. I think that I'm just an old soul in a young person's body, and they just have the best stories, and
I know.
they
Yeah.
truly do. And after doing a PT tech position, I knew it was time to go back to school and really choose what I wanted to do. PT wasn't completely off of the table, but in my experience of my experience as a PT tech, it was, it seemed like there was something missing, and I knew occupational therapy was something that was a possibility for me. I just didn't really know that much about it. So I spent, I think, like a day just looking up occupational therapy. And, I think it was that day where I told myself, oh my goodness, this is, everything that I believe in. This is everything that, I would want in a career. And just, these, I guess, mantras or just philosophies that OT has, living your best life, living life to the fullest. It was just, I think it was probably the aspect that I wasn't really seeing in PT that made it all the more go the OT direction.
Yeah.
And so at that point, I applied for grad school and, got in, and, I changed my mind a lot about a lot of things, but the one thing that I never questioned was whether or not I was in the right field. And but I did my first level 2 in an acute rehab setting, and that was wonderful, seeing the different diagnoses, and the fieldwork educator that I had, really shaped the way that I carry out my treatments in hospice now. And then my second fieldwork was in Houston at a cancer hospital, MD Anderson, and that alone was just an incredible experience. So I worked with a lot of cancer patients, and then on Mondays I was on the palliative care unit floor. So those were the things that kind of shaped, where I'm at today.
And what kind of organization are you working for currently?
So I work for a nonprofit hospice agency, and they've been around the Las Vegas area for about 40 years now. And, being there alone is just, I'm so grateful for, because they've established such a great reputation in the Las Vegas community. And, their quality of care really mirrors the ideals of OT philosophy. If you go on their website, or even just any hospice website, those key buzzwords that we use as OTs, quality of life, independence, they're very much all on there. And so yeah, and then when I entered this, when I started working with my agency, it was kind of just one of those unexpected things, coming out of grad school and passing my boards and everything. It was just, okay, what's next? So in the midst of all studying, me and one of my friends, as breaks, we would just go on the job postings, and, this could be us one day as a means of motivation.
Yeah.
And I noticed there was always something that kind of was always showing up, and it was for the hospice that I work for now. And it was a part-time position, but one of the key elements that they had there in terms of qualifications was fall prevention. And during my grad program, me and some of my peers did stepping on, which was just community-based older adults and teaching them how to prevent falls or just reduce their fall risk. And that was really enjoyable for me. And I thought, okay, let me apply for it. Not only
was it I'm sorry, I totally interrupted.
No.
Was it an OT position, or was it just about like a fall prevent? Like, was it for OT, a part-time OT position?
Yeah, it was for a part-time.
It was, okay.
And, I wasn't quite sure, because going out of school, you want a full-time position.
Yeah.
But the whole thing that kind of nailed the coffin, or nailed the, you know what I mean? It just stuck the nail in the coffin, I guess, was Nathan Adelson, so the hospice that I work for, was also the hospice that my family was using for my mom at the end of her life. And it was just one of those things where, okay, well, try it out. And, you went into healthcare for this reason. And, it would be so wonderful to work for an organization that, helped you out and brought you to where you are.
Yeah.
So, yeah, that was very empowering for me. And so I went into my interview and not really knowing what to expect. So basically, my supervisor at the time, she had returned from a conference for physical therapy, occupational therapy, and hospice, and how it could be beneficial in a hospice setting. And she was telling me, I wasn't really aware what occupational therapists actually did. But coming back from that conference, it was just amazing. And you guys do great work. And she was bringing on the therapist position for the purpose of fall prevention. So a lot of, once we're 65, our fall risk is increased. And so in the hospice setting, when they're declining and all of these things are going on with them, falls are a common thing. And she just wanted to find a way to address that and, reduce that number within our setting and just, amp up the quality of care that we as an agency provide. So that's how
that's how it got going. Are you doing is it home-based or is it in a facility?
So a lot of my visits are home-based. So a lot of patients in hospice, it's their treatments and their care teams are within their homes. We do have 2 inpatient settings. So we have a floor at one of our hospitals, and then we have a standalone hospice building with another inpatient unit. And so inpatient units, they're great for respite. So if a family needs to just take a break for a little bit, or they have something going on, but they want that peace of mind that their loved one is cared for, they'll go there. The other purpose for the inpatient unit is if there are some uncontrolled symptoms or pain that can't otherwise be managed in the home, then they're sent there until they're, I guess, stabilized or ready to go back home, sort of deal. So,
okay.
Yeah.
How would you, if someone isn't really familiar of the whole hospice and palliative care system, how would you define each of those?
So, hospice has a bad stigma, understandably, because, death, dying. But the one myth to kind of just dispel is, hospice doesn't, hasten your death kind of thing. And, if it's just really everything that OT philosophy is, hospice and palliative care, those 2 things are different, but very much related. And I'll go into that in a little bit. But basically, when you're in hospice, you have a terminal illness, and it's certified by the physician that, if the disease is to run its expected course, you have 6 months or less to live. And, with the whole scenario of the caregivers and the patient, you want to just make that experience as comfortable and, as best as it can possibly be, despite the situation. And, it focuses on just being comfortable in your home, having that independence in your home, having that quality of life, because when it comes down to it, we don't really know when we're going to pass. And, so you're not going to sit there and, wait for that to happen. You still, as best as you can, try and continue on. And OTs and hospice care and palliative care all kind of meld together to support that, I feel like, in combination with all the other staff of the team. So with palliative and hospice care, so there's also blurry lines between there, but the best way that I can describe it is, palliative care is if somebody has a terminal illness, it doesn't have to be terminal. It can be terminal, but it doesn't have to be. And, they can have that in conjunction with treatment of their disease. And then with hospice, a patient in hospice, they would elect that, they're not doing any more treatment to cure or, improve their disease status. Rather, they just choose comfort measures only. So, I mean, bottom line is comfort and quality of life are the main goals. But with palliative, you can have it at any time. You can do it while you're seeking out treatment. Whereas for hospice, no more treatment to cure that said illness.
Mm-hmm. Okay. Yeah. And I mean, and obviously you have way more experience with it than I do, but I mean, people can get off, I say get off hospice, but like you don't have, I mean, you have that 6 month, diagnosis, right? 6 months. But I mean, I've had patients in the past that, I've had in home care, then they go on to hospice and then they come back to home care, right?
Absolutely. And it's the same thing with hospice too, because, again, really no one knows when you're going to pass away. And sometimes, what's expected to be a disease that, has a fast track can certainly be slow for another person. And, as long as there are criterias that are being met, then somebody can continue to stay eligible for hospice. And if not, if they actually do get better, which, I've had already a couple of experiences where they are discharged from hospice or they graduate from hospice, then okay. I mean, that's great news too.
Yeah.
So,
yeah. Do you know what some of the other criteria is?
Yeah. So, I mean, whenever we have ID or the interdisciplinary meetings, so if somebody, for instance, has weight loss within their certification period, or they had a fall, or their PPS score, which is a palliative measure that my agency uses, starts to decrease, just a few indications of decline, then they're eligible to stay on hospice. But sometimes it's out of the decision of the family, and that is another thing that I perhaps not a lot of people might know. You can choose to sign off at any time. If you're doing hospice and then all of a sudden, you decide you do want to seek treatment to cure your disease, okay, that's fine too. And then, you can most certainly come back when it's just more of a desire. So it varies. It really varies. But bottom line is we don't hasten your death. It's just really to get you to the comfort and quality of life. And, if it goes the other way around, then at least you have the means and the knowing that it's certainly an option for you in the future, sort of thing.
Yeah. And I'm sure that's really comforting as well. Once people kind of understand like the role of hospice, I can see how, it's all the whole knowledge is power, right?
Yeah, absolutely.
Like people just feel like they are empowered to know what the rules and regulations are instead of like an old stigma of what, hospice just means that you're there to die, and it's like having that supportive team and making it a quality of life experience. Is so beautiful. Like I love, love, love that. So, so as an OT working in this setting, what do you see as OT's role? Like, I mean, because I see such a huge potential for OT, and I guess I'm just talking about like where I live. There's not a lot of OT being utilized in the hospice setting.
Sure.
And maybe it's different other places, but so I'm kind of interested in what now that you're in it, what do you see as our role?
Great question. So, I mean, going into it, I wasn't really sure what I was coming into either, because they pretty much told me that, this is something I think would be great, but, if we're not sure if it's going to stay part-time, full-time, we'll just kind of go about it and see it fit. And even in my
especially, I was just saying, like, especially since, they kind of initially started it as, fall prevention. That's how they were kind of, right? Yeah. Isn't that how they kind of were? That was the angle they were kind of going. Not that saying that that's not OT's role, but I mean, as an OT, I can see a billion ways that we could be.
Oh, helpful. Yeah. No, I mean, the fall prevention thing certainly made sense to me. And then
definitely.
But then, so when I was starting out, I would visit with, nurses and social workers on their home visits. And, with each and every encounter and being right there in the environment, it was just, oh my gosh, OT OT.
Yeah, I
And
can see it.
so to answer the question, if I could just state my vision for OT in hospice is, so in hospice there's just a base core, at least in my agency. So there's always a physician, there's always a skilled nurse, a case manager, a social worker, CNAs, and chaplain spiritual support. And what I want is, for every single person, or I guess for OT, to be in that base foundation of care staff, because you come in and, there is so much to be addressed. So with hospice care benefit, you have all of the equipment to your disposal. A lot of these things with caregivers is for a lot of them, it's their first time ever being a caregiver. So they're kind of at a loss as to what to do, how to best care for their loved one, in combination with all these people coming in and out. So, in every single one of my experiences, my first visits, it's amazing just how little, not so much knowledge, but how little is known about, something as simple as the components of DME, which OTs are well versed in, how something is positioned, how to best, support repositioning in and out of bed, those ADLs, because when it comes down to it, what makes me sad, if anything, is the lack of opportunities that people at hospice get. So a lot of them, when I first chart review, it's, they're bedbound, or they haven't gotten out of bed in weeks, months, even days. And so they're kind of maybe perhaps wired to think that this is it, sort of thing. And as my role in an OT, it's you go in there and you're the first to help them do something that they haven't done in a long time. There's so even getting out of bed, or something that, with elderly or just older adults, they have impairments of their own, and how to better manage transfers, bed mobility, activity engagement. It's engaging them in something that, they're kind of just passively not doing. So CNAs come in, they have all of these things that help them. And so, but you can help yourself too. You're not done yet, I guess. But the thing is too, is so if they are in the case where OTs aren't coming, with somebody being bedbound, that's another set of problems, skin integrity, pressure sores, even the stiffness and contractures are at play. And so in order for that to happen, or in order for something, for a person to be able to get a bed, say, they can't be super stiff. So it really truly does go to the basics, to what everything is, everything that we address in OT school, that support those things that make somebody have a quality of life. So that's, I guess that's why even it was just easy for me to come in as a new grad, because all of these things are just, foundational OT stuff. And at the end of life, those things that you aren't being given an opportunity to do, we help you do that.
Yeah. And it matters, that's what's meaningful to them. And it's like being able to re-engage in those things is so neat. How about like typical payment systems? How does that work? So obviously we're in the United States, and we're just talking about in general, just in general hospice, because that was always one of the things that people had talked about. And I don't even know how true it is, but that's one of the reasons why OTs aren't necessarily always a part of the hospice. Is it is it just awareness, or is it barriers like payment systems?
So I can speak to how our payment system works, but I would imagine hopefully that, there are hospices that run in the same fashion. But basically, so if somebody has Medicare, and a lot of the adults, older adults do, if they elect to choose hospice services, what it means is, they can't seek treatment for their main terminal illness, but by having the hospice benefit, it is this pretty much Medicare pays the hospice agency, and it's a fee that's, small or costs little or no cost to you. And what that covers are so many things. So you have a doctor, nurse, counselor, social workers, PT and OT at your care staff, volunteers, hospice aides, CNAs. And then in combination with that, you can choose all of them, or you can choose, whatever is just geared to your desire. So our agency, they have, now they have their OT, they have complementary therapies like a massage therapist. We have a pet therapy program. We have somebody that does Reiki, and then, they grief counseling, bereavement after a death.
Awesome.
And, so somebody can choose all of that into their care plan, and somebody can choose one or two. It's the same thing. And, it's just because all your Medicare benefits are Medicare will pay for it, but you're under the Medicare hospice benefit, and it covers all of that, and the DME. So all of this DME can get sent to your home, which is another role in OT, because sometimes not even the right stuff is being sent to their home, and you can jump in there and find something that's more comfortable or more appropriate for them. And then once the patient dies or passes away, it just gets sent back. But, it's just all the more support to keep them safe, to keep them comfortable. And a lot of it, the time is their first time using anything of that sort. So I get that frequently in a lot of my interventions and sessions.
Do you have any insight or any thoughts on why you think more OTs aren't working in this area? I mean, there are. I mean, I'm not saying like we're not at all, but any thoughts on that?
I think I think it just comes down to the larger scheme of things, because, we as a profession already struggle in defining our role. And, my supervisor at the time, she's been in the healthcare field for I would imagine at least 10 years. And, she was just now finding out about what the role OT can actually play. And so it's even finding the place in where hospice and therapy set in, because we're traditionally, associated with words like PT, strengthening, range of motion, which when case managers would send me referrals, that's what it would kind of be. And I think through documentation, and then, piping up, or having even just families, say how happy they are that I'm coming in, really in its own right, just advocates for what more that we can do. And these days now, when I get referrals, it's not this little blurb about strengthening and range of motion, or this person keeps falling. It's, I have multiple referrals now that is just, can you please find a way to help this patient do their ADLs in whatever way they can, or this family is at a loss for how to safely transfer. They haven't been out of bed in a while. Can you come in and see? Can you help them? And it is just, it's great. It keeps me so busy, but it's great because they are so grateful when you leave, and they're just, okay, we can do this. And they're establishing a new normal. And that's really what it is.
Oh, and it sounds super rewarding.
It is. Yeah, it is.
And I think if someone's kind of new to hospice, I think that some of the questions would be like, what are your types of goals do you write, right? Because potentially, they are at end of life, and trying to figure out like what would be some types of goals that you would write. I can think of like caregiver, because you have caregiver goals, right? And things like that. But what other types of goals would you write?
So, I mean, it's really, so a lot of the goals for my patients, they're all pretty similar. And, it's things like, reported improved activity engagement by the patient and the caregiver, or even the falls even are a huge play, because, they don't do they're not doing anything because they're fearful of falling. And so, reducing that fear of falling, and, they feel both the patient and the family caregiver, they feel empowered to be able to do things that they weren't doing before. because you're working on those different things with them. Just safety and improved activity engagement and quality of life are probably the main themes that surround my goals. Or even just, like you said, caregiver stuff, safe transfers, and sometimes things are a little bit more unique to a patient too. I want to be able to still get out in the community and be able to do. So I had a patient who had one goal and one goal only. And so the case manager was saying, "Hey, I put in a referral for you to see this gentleman. The only thing that he wants to do is be able to check his mail." And I said, "Okay, let me go see him." And so, we're wired after school to think a certain way, but these simple things, not everyone is just naturally thinking of them. And so this gentleman, he lived on the second floor of an apartment building. He had COPD, huge risk for falls, was falling all over the place, but he still wanted to be able to check his mail. And he said, "I don't care if it takes me an hour. I just want to be able to do it." And so, mapping out, the entire environment and, what his setup was like and, his energy and his energy levels, his current functional abilities at the time. So how that ended up even just being accomplished on that visit was, okay, he was still mobile. And so his downstairs neighbor also was on board with it, which makes, hospice entirely even more easier because the caregiver support you get is incredible. People are so much eager to be involved in the care plan. And so what we did, I brought his wheelchair down, and I told him, "Okay, so you and I are going to walk down the stairs together," which was something he was already doing. And granted, he took extra time, but he kept himself safe. And he was, he had a decent safety awareness where if he needed to take a break and sit down, then he was going to do it. And so I had parked the wheelchair just kind of in his downstairs neighbor area. And I said, "We're going to walk down the stairs. And then what we're going to do is we're going to sit in the wheelchair. So that way you can take a break." And then his mailbox was super, super far. And I said, "Okay, this is what you're going to do." And he was just so amazed. He was thinking, I never even thought of that. And I said, "I want you to do as much as you can. So what you're going to do is you're going to use your feet to, make your way over to the mailbox. And if you have to take a break, so be it. We'll just sit here until you're ready to go again," instead of being passively pushed, which he already appreciated. And then so we went around to the corner and he checked his mail. He went back to the foot of his stairs. We parked the wheelchair over by his neighbor's house, and then we walked back up. And it was manageable for him. The whole concept of energy conservation, the deep breathing stuff, the community mobility, all of that was at play. And he was so grateful. He left and I left. He was crying. 80-something-year-old man was crying. And he said, "Thank you so much for helping me, figure a way to do that," sort of thing. And, I think a couple of weeks later he had passed away, but, he got that just one simple wish of being able to check his mail. And it was just an alternate opportunity for him to get out in those last coming weeks. And he had a background of being an avid hiker. He would share stories with me about, going to the grocery store and walking there and just walk. And, framing it in a way where, I know it's being supported by a wheelchair, but the important thing is you're doing it and you're safe. And, once they're kind of redirected or shifted to that perspective, they're on board. I work in acute rehab, and I find sometimes it's more difficult to motivate patients versus hospice, where they appreciate every single thing that you do because they haven't been given the opportunity to do so, really.
Yeah, that's exactly what I was going to say. It's like those things, like I think sometimes it's like almost giving them permission to be able to do certain things. Like they don't, necessarily feel like they can, or not sure if they should,
Or even the way that it's
um,
approached. I think he thought that when I would come in there, I would help him walk to the mailbox and, take those 2 hours he thought that it would take. But, that's the whole thing with the I for OT, our skill set, and breaking down a task and, finding out what's going to be most advantageous for them. And, with caregivers too, it's just, oh, I never thought that. It's a really great idea. Or something even as simple as, the positioning of a wheelchair or a commode. I can't tell you how often, something is placed right in front of them, when they're doing pretty much a 360 to sit.
yeah,
But then
right.
hey, if you do it this way, honestly, all you have to do is stand, turn, and sit. And it's mind boggling for them.
Mm-hmm. I know those sound like some of those rewarding things. Like, what would you say is kind of the most rewarding part of the job?
Really, being that person to help them do their first. It's not unusual to have a patient cry because they're given these sorts of things, or even just that you have to, in a way, get so intimate and open with them, and pretty much from the get-go, because they already have these things going on with their body, caregiver stress in combination with people coming in and out of their home, and their time is limited too. So you get in there, and
Yeah.
as an OT, we have that humanistic, element, I would say, in our just natural personalities. And because I think OT would be so successful is because, you're not really so much talking about death. It's making really, you're giving them the opportunity to do. And, with other staff, which are 100% valuable, it's really just managing pain, or, they're excited to see you because you make their lives fun and
Mm.
engaging is what it is. And
Mm-hmm.
and I think too, being a younger face, and kind of treating them as they're human. And sometimes I forget that I'm even in hospice, sort of thing. And
Yeah,
it's just,
I could see
you're
that.
just having fun with them, and you become almost a part of their family and what they look forward to. And it's not all sad and gloomy all the time. If anything, I
Right.
see it the opposite way. And you're just really in the moment with them, doing the best that they can, you doing the best that you can, and that's enough most of the time.
Yeah, helping them live,
Yeah.
What do you think are some of the challenges then? I like every setting has challenges.
Uh-huh.
What's the most challenging of working in hospice?
It's, if there's anything that I would say about the challenges with hospice, is that there aren't more OTs, because just
Mm.
being here a little bit over a year, you see just this realm that's untapped, with the basics kind of thing. And the fact that if there's anything that makes me sad, I know that I help the patients that I'm seeing, and I'm helping support their quality of life and empowering the families that, it doesn't have to be this unpleasant, gloomy thing. What makes me sad is, okay, in our census of 300 plus in the Las Vegas community receiving hospice services, how many of those people um, are just sitting there thinking that this is it, sort of thing. When
Mm.
I meet people for the first time, and I hear their background of, I've been kind of stuck here for the last 3 weeks, months. How many people of those are existent? And probably 50+% of them, kind of thing.
Hmm.
It's hard to think about that, where you're doing something really good for OT, the community, just patients and families, but how many people are deprived of that? We had a social justice class in grad school, and we talked about marginalized populations. I think hospice community
Mm.
is a marginalized population because it doesn't have to be a bad death, sort of thing.
Mm. Hmm. Yeah. Yeah. I that's why I was asking a little bit early, we were just kind of chatting about why aren't there more OTs in there, in working in these types of settings? Just because I feel like there's so much that you can do and offer. And obviously you are seeing that as
Yeah.
well. And I'm sure some of the hard things, and or have you had any patients that have passed away? And I think that's something I know that I've had questions about that. Like, how do you do, not even just working in hospice, but, like, how do you deal with that?
It's a question because I get that asked frequently, and I'm not
hard.
sure that
Yeah.
I ever have the set response for it. And,
Yeah.
perhaps it has
Yeah.
to do with kind of my own experiences with death and how I handle things. Because the depression, the even the suicide ideation, the just I don't want to live anymore, that is pervasive. I talk about the positive aspects of it, but the reality is a lot of them are dealing with a lot, and you have to address that. And that's when the whole concept of therapeutic use of self comes to play. And I think that even just, speaks to OT and their role, because, they're looking forward to seeing you. But I think not even just because you help them with the act of doing, is because you're really in there and you find out what it is that makes them the person they are. And, you help them navigate through something. We have social workers and we have chaplains that, all do that as well. But, OT has that mental aspect in their scope of practice that truly support that. But, it's hard. I don't know how I deal with it. I guess I just, do.
Yeah.
It's, I think I just really more focus on the now and how, if anything, you helped them kind of thing. And I just try not to think about it. And I don't, I think I've just been naturally wired now to see more of the positive. And, I would be lying if I said I didn't bring it home with me, because occasionally I do, but, it doesn't take over me that, I question if it's the right setting for me or not. Practicing in just other self-care and just, knowing that you're doing the best that you can is I think is enough. And you're helping change the way that death is viewed. You help somebody have a pleasant or just better end of life experience. And, it's not really so much death that's on the horizon and at the forefront of my thoughts, but I really don't know how I handle. I guess I just do.
Yeah. And there's no answer. And I agree. I mean, I think it is so individualized. I know, especially for me personally, at the beginning of my career, I just really had a hard time separating. And not that I don't separate it now, or not that I separate it so much now that I don't have, the feelings of, having those patients that, have passed, but I'm at the point now, that I really just focus on the positive as well, and really try to just think of it as, what they've accomplished through their lives and what my role is, and how did I help them as best as I could during the end. Not that I worked in hospice, but just working in skilled nursing for a long period of time. It's just, and you still have those patients that it hits you hard.
Absolutely.
I had a patient, and I maybe have talked about her on some past episodes, but I had a patient where, because when I graduated out of OT school, I went right into home care. And so and I work we call it a valley. So you have a lot of these little tiny resort towns with all these little hospitals, and you have home care and assisted living and nursing home, right? But they're all these little towns. But I saw her in home care. She was like one of my very first patients ever. Well, then I saw her, then I was in, I did acute care. I saw her in acute care. Then I saw her in outpatient. and then I, cause I've kind of worked in all sorts of settings. And then, at the end, she was in the nursing home, and she was a lady that had lived through the depression. So very, very, very frugal woman. And she also she had a stroke, giving birth, to her like one and only son when she was in her mid-20s. So she had, like a left hemiplegia for, years and years and years and years. And, it's one of those things that you just have those patients that you just,
Oh,
love.
yeah.
And especially with her, I've seen her in so many settings. She'd say, and she was one of those people that always say your name. She goes, "Oh,
Yeah.
man. Oh, man." Oh, and then she'd always be like, "Oh, you need a foot in, a shoe
Yeah.
insert," like, because she'd like wrap paper. Like I said, she was very frugal. She'd wrap newspaper and create her own little like, orthotic type thing. We'd be like, maybe we should get a little bit more
Right.
support so you're not falling. And she'd be like, "Oh man, oh man," it's like this whole thing. But and weirdly enough, and I've worked in the last few years, just worked PRN at a bunch of different skilled nursing facilities, but she was at end of life in the skilled facility that I was in. And I just happened to be there that day. And, she was, resting, she was in her bed, and they're like, "Manny, she's going to be passing here soon." And I was able to was fortunate to be able to spend those last few moments with her. And like, it's just one of those things, like it kind of comes full circle sometimes. Like, what is the chance that would happen while I was there with her? You know what I mean? That I was there. I don't work that often at the facility. And it was just like, it was so sad. It hit me hard. Like, even just talking about it, I'm like, "Oh, okay, take a deep breath." But also, like, what an amazing journey that I got to be a part of her life, even just a little bit. And, I just try to relish those fun, crazy, frustrating, amazing moments that you have with some of those patients through the years. And I don't know, but yeah, that one was one that really hit me hard, but gosh almighty.
And she was, I'm sure she was really lucky to have you as such a compassionate person in her life, whether it was just throughout a whole, just even in and out kind of thing. And it's, and I guess that's the bottom line too. It's just, the interactions that you have are so valuable. They want that time with you. And so even on my just worst of days, you have to kind of just, you have to be your best. And when you operate in that fashion and you get as much as you can done, because you can literally they'll be gone the next week, sort of thing. And I try to also see it now as, I'm not, we go into healthcare to, make a difference in people's lives. And, I know for me, I want to make a difference in the world, but at the same time too, you can't save everyone. You just have to focus on, those little, and I would rather have 10 very, very meaningful encounters in my lifetime than, 1,000 that are just, you're in, you're out. Okay. You're in, you're out. And I think that's an element that's, just missing in healthcare in general, that human interaction, that, vulnerability, a lot of these people, we have some of the best conversations. And I think that's another thing that makes the OT in this position just so successful and so sought out, that, I would love to see my patients more than once a week for some of them. But, I'm just trying to address, the evals, they take priority, because more often than not, you're getting something done, and they're just, it makes their journey at the end of life, at least a little bit better. So, but yeah, it's that part's difficult, but you just do the best that you can. And, in your own small way, you just make that impact for them.
Yeah, I completely agree. And sometimes I think it's hard because you have all these other expectations. You have your paperwork, and you have, I don't know if you're supervising someone, or, then you have the demands of the different facilities or the companies and different things like that. But sometimes I think you're exactly right. If you can just focus sometimes on those little successes, it really, it does help. And I truly believe we are making a difference. Like, we make a difference in the lives of our patients, and it's like, sometimes I, as somebody who's worked for a long time, sometimes, you get in the grind and you kind of lose that a little bit. So I think I think it's important to reflect on that sometimes. Why did we get into this in the first place? And, easier said than done
Yeah.
sometimes, but also it's like those little, you see those little joyous
Mhm.
moments with your patients and you're like, yep, that's it. Oh man. Okay. Like,
Me and my student are seeing a patient right now. And I mean, even before I saw him and reading his chart, it was just, the depression factor was at play. The documentation would, report him just, sharing to whoever was seeing him that, I don't want to live anymore. What's the point if I'm just, lying here? And so me and my student, we see him now, and yeah, it's not absent. That depression, is still there, but by the same token, he is always dressed and ready for us now. Sometimes when we let him know that we're coming, if we're running a little bit behind 30, 40 minutes late, I get a phone call from him saying, "Hey, are you still coming?" And I said, "Yes, we're just running a little behind on our way." And
yeah.
that although, that depression element is still there, the more, I guess, notable thing to look at is that you are that one person, or two persons in this case, that in their day-to-day, in their weeks, it's that spark of hope. And I think that is just another description of what our place is. You give somebody that spark of hope that my life doesn't really have to be this way. There's something that I could do. Because whether you're 6 or 106, I tell my patients all the time, that sense of independence is still there, without families even knowing, what OT philosophy is, that independence, that quality of life thing. They tell me, my mom has always been just super independent. My dad has always just done things his way, and he's having a hard time accepting this. And it's just, well, here we are. We're going to help you be as independent as possible, within the limits of your, comfort and your safety, your disease process, and,
Yeah.
redirecting them to just, again, that new normal. And, when they're kind of, okay, I've never used anything in my life, but I can see now how this will help me, sort of thing. I think is when, all the more they become really, really involved and carry out that care plan.
Absolutely. And, I kind of think that there's always, as someone who is a somewhat controlling, not controlling as in like, well, I like to not think bad, Nick, controlling, but like someone who likes to be in control of things. Like, I think that gives people I think it gives people a sense of control when they feel, they're like, I can do this. I can be independent. I do have a little bit of control in a world where, they don't have a lot of control over the disease process. And so I think those are little things that I think really, really
And
helps.
that's an excellent point that you made, because when it comes down to it, they have people coming in and out, and we're very well-intentioned caregivers. We find more often than not, it's just, it's in a way, it's overbearing, and they can be encouraged to do something as simple as, their grooming routine. And when you have CNAs coming in and out, they just kind of, okay, well, I'll just let them help me, sort of thing. And I don't have control, or I don't know what's going to happen. And a lot of people, I can speak to that. And I think maybe that's why, not just having an OT skill set, but, I'm very, I like things my way.
Me too. That's
so
what I'm saying.
I can't really, sometimes, especially with cognition, or even just, you just kind of accept this as your new norm. I don't have much control, and that's what gets to a lot of people too. So when they have something simple that, hey, I can start doing for myself, and you even encourage caregivers to do things, or to let their loved ones do things for themselves, and it makes their caregiver burden a lot less, and empowers the patient to be independent and move, because the best form of exercise is moving, and those functional activities. And people who I see that might just be coming in there, I just want you to teach me how to exercise. It's just, all right, we can put that as part of your care plan, but in all fairness,
right.
The best form of exercise. So let's practice transfers, or let's get you, you go through those things, and they're just, oh my gosh, I didn't know how much that can take out of me. And it's just, okay, well, what I do once a week isn't going to even scratch the surface. So the bottom line is, I can only do so much, but it's what you do when I leave these doors, and more often than not, they do their homework, and so
Mhm.
it just puts the
No.
sessions at a better place. It puts them in a better place, and you know, improve just the quality of the experience, I'd say.
Yeah, for sure. So if somebody is kind of interested as an OT, interested in working like in a hospice type setting, do you have any like key takeaways or qualities that you think a person maybe should have? If
Yeah,
do you
yeah.
know what I mean? Like, what would be some things that would be
Great
helpful?
question. So patience is key, because sometimes, I had a patient that was pretty much bedbound, but pain was her biggest limiting factor. But in 45 minutes, and in combination with being a little bit on the heavier side, um, at first glance, it's okay. How am I
Mhm.
going to get this person to sit up if she has like 9 out of 10 pain all the time? And you know what? We got her out of bed or sitting up at least with little to no pain. And, that had a lot to do with just bed mobility strategies that we're well versed in combination with the relaxation pursed breathing. That is something that I address with every single one of my patients, because
Mm.
more often than not, they are scared of doing something that they haven't been doing. And so, you can tell that they're
Mhm.
tense, and sometimes they're on oxygen too. And so they become more reliant on that. And you can physically see that they hold their breath for the longest time. And, when you kind of get them into those good habits, it's amazing what they can do. So she was able to sit up, edge of bed, and I mean, it took 45 minutes, but that was really, really empowering for her. It
Mhm.
made what seemed like a scary experience actually really, really great for me as an OT. And hey, this is a possibility for her. And yeah, it's just kind of, and they'll talk you through a whole bunch of things. Sometimes they'll repeat their same stories, but they don't get a lot of opportunities to express themselves either. And so being patient with that and really
Mhm.
exploring or just having that attentive eye is important. I think too, just being able to handle the tough stuff, have tough conversations, but they're not
Yeah.
really tough. It's just about being open, sort of thing. Um, you know, being okay with being vulnerable with a patient, and I wouldn't say that you necessarily have to have your own death experiences, but I think that's certainly something that's helped. And just kind of seeing how my mom, how
Yeah.
she wanted
I
that
could see
sort of
that.
independence. And that was even before what I knew OT was. I think something as simple as her being able to wash the dishes or prepare a meal for her kids would have made her feel a little bit more like she still had a reason to live. So um
Right. Yeah. Having those firsthand experiences definitely
yeah,
kickstarts that passion for it. You know what I mean? And like really see it from such a different perspective as well. And I think it's one of those things you're like, oh man, that you had to go through, but also like what a beautiful gift that you get
right.
to share with others because of it. I think is
The last thing that I would
just a kind
probably
of a
add
neat
to,
perspective.
I guess something that would be useful to have is just really kind of having that approach to, living in the moment and already having appreciation for small things. It's so easy, just us as in general, to get wrapped up
Mm,
and be outcome driven, especially in the therapy field, is okay, independence, or, you get better. It will be 100% different in hospice. What you're focusing on is for that moment right then and there, what you were able to do with them, not that why am I here, they're gonna die anyways kind of thing.
mm,
It's just right
mhm.
now, right here.
Right. Gosh, that's a beautiful way to put it. I love all your insights and it's and sharing your kind of your OT journey with
Thank you so
us.
much,
So I
Mandy.
thank
I
you so
really, really
much for all of
appreciate
this
it. And
today.
Yeah, I'm sorry if I talked your ear off. There's just so much to be done, and I hope I can perhaps get more OTs on board in this setting. And I really truly feel like it'll be my life's work to make a name for OT and hospice, and you've given me that opportunity to at least extend my reach. So thank you.
Oh gosh, of course. Yeah. And if anybody has any questions, feel free to reach out to me, and we can kind of get everyone hooked up with resources for working in hospice and palliative care. And I'd love to see OT expand a little bit more a lot more in this area as well. So thanks again, Carmella, and thanks everyone for listening. So until next time.
Do you feel like you're navigating the OT world without a map? Not feeling confident or competent in your day-to-day treatments and struggling to apply your knowledge clinically? Then be sure to check out the Seniors Flourish Learning Lab membership. It has all of the treatment ideas, patient handouts, clinical resources, community support, and mentorship you need to succeed. Join today at seniorsflourish.com/learninglab.